Good evening, everyone. Welcome to this webinar entitled Ultrasound-Guided Dry Needling, presented by Scott Epsley. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to explain the advantages of ultrasound-guided needling over unguided techniques, understand approaches to ultrasound-guided needling, be familiar with the sonographic appearance of larger gauge acupuncture needles, know the difference between clean and sterile techniques, give examples of the applications of ultrasound-guided needling, and cite precautions associated with needling techniques. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Scott Epsley and Darcy Bolito de Luna have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME test credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Scott Epsley.
Thanks, Darcy, and welcome everybody. Thanks for joining us on a Monday night, first day back at work for the week, and a late night of learning, but hopefully you find this beneficial and enjoyable. So as Darcy said, I have no disclosures to report, and I just want to start out with a little outline of what we're going to go through. We're going to talk about dry needling principles and some of the evidence behind. This is not intended to be a review of dry needling. We will discuss that, but this is really to demonstrate the application of ultrasound-guided dry needling. As part of that, we will discuss myofascial trigger points because it's relevant to the practice of dry needling. But again, it's not intended to be a review or discussion on that and pertaining to the evidence thereof. We will also discuss advantages of ultrasound-guided dry needling over non-guided techniques and when ultrasound-guided dry needling may be applicable. And we will then go into the actual technique of needling. And these needling techniques are not just unique to dry needling, but also to wet needling and joint injection. We will discuss examples of ultrasound-guided dry needling in clinical practice and the sorts of locations that might be appropriate for needling, the muscles that would be most appropriate to needle in, and then finally a brief discussion of peri-neural needling in managing musculoskeletal pain. Before we go any further, I want to say that, again, this presentation is not meant to be instructive in the sense that at the end of it, you are able to perform ultrasound-guided dry needling. This is something that is a high-level skill. The ability to manipulate the ultrasound transducer with one hand and the needle with another hand is a practiced skill and something that takes time. It is also important that you have a good 3D visuospatial orientation and ability to orient yourself with the ultrasound. There are various methods for practicing this. People use an olive in a chicken breast, for instance, to practice, and there are various other methods for practicing this. So You know, this is not meant to be completely instructional, and at the end, I've been needling now for 18 years, and I've been using diagnostic ultrasound in clinical practice for 14 years. And so this is a skill that I've developed over time. So let's just look at dry needling. It's been defined as the insertion of an acupuncture needle for the purposes of treating myofascial pain. You know, we want to define the difference between dry needling and acupuncture, as long as we understand that whilst the technique and the needles are similar, we are using a 0.25 millimeter to 0.35 millimeter for most dry needling techniques needle, which is equivalent of a 31 to a 28 gauge needle. By way of example, joint injections are generally somewhere in the vicinity of a 22 gauge spinal needle or a 0.71 millimeter needle. So the needles that we're using for ultrasound guided dry needling are much harder to see than for wet injection under ultrasound, generally speaking. And again, that means the technique is somewhat difficult, but still very, very doable, as you will see. But this is clearly different from acupuncture. We're not following the meridians per se. There is definitely overlap. Myofascial trigger points definitely overlap acupuncture points. There's no question about that. There's multiple examples of that throughout the body. But the general principle behind what we're trying to achieve, and this should become apparent in the next few slides, is different. So that being said, we should probably go on and define what we really mean by a myofascial trigger point. Now, it's possible to needle many different structures, and people talk about needling tissue from tendons to muscles to the periosteum. I would say that personally, I really keep my dry needling to needling the periosteum and needling myofascial trigger points. I don't. And this is a personal belief from the literature, and my beliefs believe in needling inside a tendon for various reasons and beyond the scope of this lecture. So we're going to really keep this discussion to myofascial trigger points, which have been defined as this palpable hyperirritable nodule in skeletal muscle. Jay Shah at the NIH has done a lot of research in this area. There's certainly been some debate over the years as to the existence of myofascial trigger points and what they really are. This concept was popularized by Travell and Simons, and certain people have definitely suggested that myofascial trigger points are not necessarily a source of pain or problematic, but I think there's sufficient evidence to point us in the direction that they are. And again, a lot of Jay Shah's work is helpful there. What we see is a decreased vibration amplitude on sonoelastography. So when you look at that, we'll see a picture of this in the next slide, but when you look at a picture on ultrasound and a vibration is applied, the elastography picture shows a decrease in color in the center of the trigger point, which represents a decreased vibration due to the change in stiffness of the tissue. We see inflammatory mediators and neuropeptides. We see cytokines and catecholamines. So Jay Shah developed a microdialysis technique to sample the fluid in the region, in the vicinity of trigger points. And this is what he found. And we also know that things like adrenaline are neuroirritants. And so there's this element of neurogenic inflammation that's going on at trigger points. And there's also altered microvascular flow on Doppler, so increased resistance to the microvascularity in the region of the trigger point leads to an alteration and an increase in pulsatile flow on Doppler. So that's really what we're talking about when we talk about a trigger point. Here's an example of the ultrasound elastography, and you can see on the right there the change in appearance with that dark area in the center of the trigger point and that hypoechoic area on the left that identifies the trigger point. So what are the benefits of dry needling? I mean, there are certainly studies that demonstrate positives and negatives, and again, that's beyond the scope of this seminar to discuss in its entirety. But for sure, we've seen benefits both in research and clinically. There's demonstrated decrease in pain and increase in range of motion. And while some of these may potentially be transient, they still are part of an overall improvement that, you know, this is not the only technique we're applying during our treatment, where we're using dry needling as an adjunct to the whole of the treatment. And so in terms of decreasing pain and improving range of motion, that may enable us to then go on and improve activation of certain muscles, improve the mechanics for certain movement techniques that we're trying to treat. We see improved homogeneity of sonoelastography appearance. So that would imply that the stiffness of that trigger point and the tissue there is returning to normal. We see improved microvascular flow, so a decrease in resistance of that microvascularity, less pulsatile nature on the Doppler flow. And also, Jay Shah showed this flushing out of the biochemical milieu that we discussed previously in the previous slide. So there's definitely both physiologic benefits at a local tissue level, and also you know, benefits from a movement and pain perspective from dry needling. So why would we use ultrasound-guided dry needling as physical therapists? There's definitely, or physicians, there's definitely people needling blindly and being very successful, and certainly I did that for the first part of my career before I became proficient in ultrasound. So the main reason really is to enhance safety and to improve the accuracy of needle placement. And hopefully, as we move through this seminar, we'll go on to see where and which parts of the body that is particularly beneficial. But if you're in the vicinity of neurovascular structures, if you're in the vicinity of viscera, the safety of ultrasound-guided dry needling is really enhanced. It also enables us to do techniques such as peri-neural needling, which we'll go on to describe and give examples of. And the other thing is it ensures that we can avoid entering a joint space or a joint capsule. And the risk of infection in the joint is significantly higher than just intramuscular needling. And that's of importance when needling, particularly around the knee, I find, but certainly various other joints as well. So let's talk a little about the technique of dry needling. There's two ways that we can needle. We can use a direct technique, and that is where we visualize the needle throughout the whole technique. And that's the most common technique, and that's the technique that we're going to talk about today and demonstrate today in this seminar. We can also use an indirect technique, and in an indirect technique, the ultrasound is used to find the tissue, to measure the depth of the tissue that you're trying to needle. And then you remove the ultrasound and you choose your needle based on the depth, and you can then, without having visually guided needling, you can insert the needle. And it's certainly a technique that I've used from time to time, but most commonly using a direct technique. So in the direct technique, we have two options. We can needle what's called in plane, and we have some slides to demonstrate this if you're having trouble getting your head around this, but the needle is inserted under the long axis of the transducer. So it's parallel to the transducer, and you can visualize the whole needle throughout the insertion. The more parallel the needle is to the transducer, the better the image you get. And body contour can make this a little difficult, and the direction that we're scanning in can make this a little difficult. For instance, scanning long axis to a muscle may mean that you need a longer needle in order to keep the needle parallel to the transducer. So we see some examples here. If the needle is not parallel to the transducer, we don't get as good an image of the needle, and it can be difficult to see. If we're using a convex transducer, which you can use, a curvilinear transducer, again, it's best imaged when it's more parallel to the transducer. This is the type of image that you get, and this is an example of a much smaller gauge needle than what an acupuncture needle is. And underneath that image, we see this example of reverberation echo. So what you see under there are these faint little lines that are echoing underneath the hyperechoic white appearance of the needle. You can see that here and here, and as the reverberation echo appears under the needle. You don't tend to see that as much with an acupuncture needle, but you definitely see that with larger gauge needles more so. So just be aware that reverberation echo is something that it can also interfere with, knowing where the needle is placed if you're not aware that that's what you're seeing. You may be unsure of your needle placement. So that's an artifact to be aware of. So here we have an example, a cross section of the forearm that we're imaging in short axis here. And we have an example of the needle, the black line, inserting into the forearm flexors, coming from the side. It's in plane, it's parallel to the transducer, and that's what we're going to do with an in-plane direct technique. So now that brings us to an out-of-plane technique. And in an out-of-plane technique, we would approach perpendicular to the transducer. And the main reason for this is just simply the shape of the body part, and really being able to see the needle and appropriately with the transducer appropriately positioned. So that can make it difficult to do it in plane, so we're going to do it out of plane. With this technique, you can only visualize the needle tip and the portion of the needle that's directly under the portion of the needle that's directly under the transducer. So you need to be aware that the length of the needle is important, because you don't know where the rest of that needle is going, because you only see the part of the needle that is directly under the transducer. This is useful if imaging in long axis, as I said, but you need, because of body dimensions, you need to come in from the short axis side. And it can also be a little bit difficult to determine the location because you're not directly imaging the whole needle throughout the whole technique. So this is a little more tricky. And here's an example of what you would see. The needle coming in from the perpendicular angle, and you just see this little bright spot underneath the transducer. And you can see that you don't really know where the end of that needle is, but you just know where the part of the needle under the transducer is. And here's an example here where we're imaging the forearm again in long axis, but we're coming in this out of plane approach directly underneath the transducer from a perpendicular angle. So we also use a clean technique with dry needling under ultrasound guidance. Sterile techniques are used for joint injections, and they involve sterile gloves, probe covers, sterile gel, betadine swabbing of the area, etc., etc. But I use a clean technique where the needle doesn't touch the ultrasound gel or the ultrasound transducer. I wipe the transducer tip with a cites cleaner. We can use alcohol swabs, but some of the rubbers in the transducer tips can be affected by the alcohol. We use sterile gel for this technique just to be extra safe, because ultrasound gel has been shown to harbor lots of bugs. We have a slide to show how many bugs you can see on the transducers following this. And then wipe the skin with alcohol. So that's the procedure for a clean technique. Here's just a little example, and you can see that an unclean ultrasound transducer with these 150 colony forming units on the left-hand side predominantly, and just wiping it with alcohol swab minimizes that mostly to zero. So definitely important. So let's talk a little bit about some of the muscles that we might use ultrasound-guided dry needling for, and the benefits and the reasons that we would do that. So the Popliteus is the first one we're going to discuss. And in clinical practice for us, particularly in sports medicine, because of its attachments onto the lateral meniscus, lateral meniscal pathology can cause a lot of spasm in the popliteal muscle, among other things, but this is by far one of the most common things. The patient will describe this kind of catch or this pain in the back of their knee. They may not be able to fully extend their knee because of this tightness in the back of their knee, and definitely have had great success with this with a number of athletes who've been able to play as a result of having, you know, their popliteus released under dry needling. It's a deep muscle under the head of the gastroc, so it's much easier to get to with a needle. The problem with it is that, as you can see in this image to the right, the neurovascular structures run right over the popliteus muscle. And in fact, I've measured this on ultrasound, and you have less than a centimeter of a gap there. So very, very small gap. Now, when needling the muscle, you can needle it perpendicularly, but through the head of the gastroc, but you don't tend to get quite as good a result in my experience. So I like to come in from the medial side, much more in the long axis of the muscle, and needle much more of the muscle belly. And I find that's more effective. And for that, ultrasound-guided needling is super important. So we have an in-plane direct technique to do this, where we're scanning the leg in the short axis, but the muscle really in the long axis. And a 0.35 by 75 millimeter needle with a linear transducer. If we take a look at this next image, this is with Doppler, and you can see the gastroc is the G, the tibia is the hypoechoic or anechoic region at the bottom of the screen, and the popliteus muscle, there's the border of the tibia, and the popliteus muscle colored in blue. So you see there's not a lot of space there coming in from that medial side. So there's the technique. It's an in-plane technique. You can see me inserting the needle medially right just above the tibia. In fact, you're just off the periosteum, almost scraping the periosteum on the tibia there as you come in from the medial side. And here's a little video playing this, this needling technique. You can see the needle to the left of your screen coming right into the muscle there. And there it is there. And you can see that we're well away from the neurovascular structures as we needle. So that's one example of ultrasound-guided dry needling and why we would use that in preference to a blind needling technique. The next one we're going to demonstrate is flexor hallucis longus, FHL. And FHL dysfunction is very common in a lot of different athletic populations. We see it in dancers, and it changes the mechanics, and then coming up into demi-point position, we see it in basketball players and many different athletes. They tend to lose dorsiflexion range of motion. I recently did a cadaver study, incidentally, or a cadaver dissection, should I say, on untreated, unembalmed cadavers, and we had a cadaver that had a decrease in dorsiflexion range of motion. We cut the Achilles tendon, and it didn't change the dorsiflexion range of motion of the talar crural joint. But after cutting FHL, it restored dorsiflexion range of motion. And that really highlighted to me just the influence of FHL. And you can get various problems in the posterior ankle region related to FHL. So needling FHL further up in the back of the tibia and the fibula is important. So remember that its origin is onto the back of the fibula and a little bit into the interosseous membrane. Remember that it crosses from the lateral side to the medial side as it runs down the leg. The best way we're going to needle this is an out of plane, again, short axis to the muscle and to the leg this time. And we're going to use a 0.3 by 50 millimeter acupuncture needle with the linear transducer. Here's a little picture demonstrating the location of these muscles. You can see the fibula is the FHL there is the slightly less echogenic structure just to the right of the fibula, and then the soleus and the gastroc muscles overlying that. In terms of identifying the FHL, you have the patient do a little big toe contraction, and you can wiggle that big toe into flexion and extension as well and see the stretch on the muscle. So this is just a little example there. You can see right where we identified the FHL on the previous slide, there it is contracting, and there it is relaxing. So best way is to identify FHL that way, and then you know you're not on tibialis posterior, which is just over to the right of that on the screen here. Just playing that once more for you, you can see that FHL. And so again, remember we're coming in perpendicular to the ultrasound transducer. This is an out of plane technique, and we're going to have a look at that now. as we bring and introduce this needle. All you see the twitch of the muscle as I entered there, and all you'll see is this little point. You can see the muscle moving, the myofascial structure moving as the needle tip enters the muscle. Just to play that again, you see as I enter the muscle, the tip of the needle there, you see that twitch response, and just you can only see the tip of the needle and the movement of the tissue around there. That little technique there where you just oscillate the needle back and forth is a very useful technique, particularly in an out of plane, but also even in an in plane, to identify where that needle is. And so that's how we identify that, even when we can't see where the tip of that needle is. Another area that's really useful to needle are the hip rotators, and particularly piriformis and obturator, partly because doing it under ultrasound is good because of the proximity to the sciatic nerve and neural structures. So if we have a little bit of a look at where these lie on ultrasound, one of the best things to do is use our bony landmarks. So we have this curve of the ischium, and then we have this flattening out of the ischial spine, and then just inferior to that, we would identify the obturator gemellus complex. And so if we look at how that looks, to use a technique for needling both of these muscles, we would use a direct technique, and it would be in plane. We're going to use a curvilinear transducer because these muscles are deep under the big glute max muscle, and we're going to use again a 0.35 by 75 millimeter needle, so fairly long needle. As we go down, we start at the PSIS, and again, we are perpendicular to the body, but we are in plane with the external rotator muscles of the leg. And we identify that on the right of the screen, the ischium and the piriformis muscle comes into view as the first deep muscle. And we can rotate the leg into internal and external rotation. Patient is lying prone at this point in time, and we're rotating the leg, and we can see that piriformis muscle move into internal and external rotation. As we move down a little bit lower, we see that ischial spine where it flattens out, and then the next thing that comes into view is our obturator. Here we have a picture of the piriformis. The piriformis in this paper that was done on injecting around into the piriformis muscle for piriformis syndrome is hyperechoic, where that black arrow is the piriformis muscle, and just to the left of that you have the sciatic nerve. So you can see that there's definitely just underneath the piriformis muscle definite proximity to your needle if you're injecting this blind. Now, if you stay very lateral, you're probably quite safe, but if you got a little medial, you would certainly have the potential to be in the vicinity of that sciatic nerve. So we're going to just go down here and have a little bit of a look as we scan down and find the piriformis. It just starts to come into view here, and you see me internally and externally rotating the leg, and you can see the piriformis muscle deep to the gluteus maximus muscle in the same location that we saw it in those still images. I'll just show you here, scanning down the gluteus maximus, finding that piriformis muscle, and then internally and externally rotating to accurately identify it. Again, there's an example of the technique using the curvilinear transducer. It is an in-plane technique, and here we have the dry needling technique here. So you will see the needle entering from the top left through the tissue. You see it's just about to pierce piriformis. Now we got a nice little twitch response, and you see just oscillating the needle inside the muscle. So once more, coming down through the glute max, just about to pierce piriformis, get a nice little twitch response, and then there we go, and we're inside piriformis there, and we're safe. So probably one of my favorites to talk about with respect to ultrasound-guided dry needling is quadratus lumborum. And again, I did this cadaver dissection a few weeks ago, and it really highlights what I've known from my ultrasound training and scanning, is that this muscle is really, really deep. And as we look at this cross-section of the abdomen and trunk, we can see that the multifidus and the paraspinal muscles overlie it. We know it comes off the transverse processes, and it's very deep. And the other thing to keep in mind is that underneath the quadratus lumborum is the viscera, and when you get a little more proximal, above L3 on the left, you have the inferior pole of the kidney. So there's two things I would highlight here. If you're needling and you think you're in quadratus lumborum, there's a very good chance that you're not, because it has a very thin sort of appearance when you're approaching it from the lateral side, and you're probably getting into the paraspinals. The second thing is, if you are in quadratus lumborum and you're taking a little bit too much of a steep approach, then you do run the risk of then getting a little too close to the viscera, and if you're too proximal, you run the risk of that inferior pole of the kidney. And that's a risk I'm just not willing to take. I do not need QL without ultrasound guidance for those reasons. So we're going to use a direct in-plane technique, and this is a short access to the muscle that we're needling it in, and it's a 0.35 by 75 mil needle. I use a curvilinear transducer for this. In thin individuals, you can use the linear or even a virtual convex. The reason I use a curvilinear is just the array of view that I get. The field of view is much wider and broader, and that means that I can visualize that needle further from the beginning of inserting the needle to actually needling the QL. So just a review of our anatomy. Here we've got the transverse process is the anechoic structure on the right, the multifidus and erectus spinae above and to the left, and the quadratus lumborum appearing to the left. And then underneath that, we will have either the viscera or the inferior pole of the kidney. So if we move to the next slide here, I would just run through those as they pop up. There's the quadratus, and then there is the area that we don't want to be in. If we move to the next slide here, I just scan through to show the inferior pole of the kidney, and then coming down onto quadratus lumborum, you should see that. Try that again, and there we go. And there's that hypoechoic inferior pole of the kidney right there, and then it disappears out of view, and there's our quadratus lumborum in view in the center of the screen, that ovoid muscular structure. Let me just play that again. We have that inferior pole of the kidney, and there it is disappearing out of view now, and then we have the ovoid quadratus lumborum. So again, here's the technique. I do this lying prone. Some people needle this in side lying. I just find this for ultrasound guided much easier to do it in this position. Coming in from the lateral side in plane, and if we have a look, here we are needling QL. Here's the needle, it's coming down close, about to enter the QL, and you'll get a nice little twitch response as I pierce the fascia of the QL. There it goes there, nice little twitch response. That twitch response is said to be important for those who haven't dry needled. It is said to be important for the release of those trigger points. That's what you're after. And so we like to see that gets us excited. So another one that we're not going to demonstrate in this lecture here today is the psoas, and this is probably the scariest and trickiest. This is something that I really reserve for very rare occasions, but that I have certainly needled. I've needled very, very successfully for anterior hip pain and kind of lower abdominal pain that is emanating from the psoas, and that I couldn't resolve with manual skills. And so again, when we look at it, we have to pierce the quadratus lumborum, and we see the psoas wedge right up against the vertebral body there. Now, if we go too much deeper into that, there are some pretty important vascular structures for the rest of the body, and we certainly don't want to enter into that space. So this one's a little precarious. We use a 100 mil needle. So it's a very long needle, and we use a thicker needle for this, a 0.5, just because we don't want that needle to bend as we're inserting it, and we've got a long way to go. I image posteriorly with the ultrasound transducer, the curvilinear transducer, and then I insert the needle just from the lateral side, just above the iliac crest, and angling down toward that vertebral body. The goal is you want that needle to kind of angle and hit that vertebral body because that's where you're safe. So again, in this picture here, the red on the left demarks the viscera where we don't want to be. The space on the right is the psoas, the quadratus lumborum is outlined in blue over the top, so that on the right of your screen, the right lower quadrant of that ultrasound image, you can see the circular pattern of the psoas muscle. And there it is there, just outlined. And so here is an example. The needle is entering in from the left, the vertebral body there, and that's the psoas. Just to the left of the vertebral body, that anechoic area. There's the needle path tracking right down through there. So let's talk a little bit about peri-neural needling. So we know that certain musculoskeletal conditions, myofascial pain conditions, can irritate along the course of nerves and give us neural symptoms without there being necessarily a focal, direct neurocompressive pathology such as disc herniation or anything directly pressing, a cyst or anything directly pressing on the nerve, but we can get irritation of that nerve, and that can be generated by muscle spasm anywhere along the course of that nerve that can inhibit the gliding and the motion of the nerve. And so something that I found particularly beneficial is the use of ultrasound-guided needling just around these nerves into the muscles that those nerves run around, and the fascial structures that those nerves run through, so that we can help to improve the mobility of that neural pathway. And that definitely seems to have an effect not only on local pain, but on some of the more distal neurogenic pain that people get. One example of that is the lateral femoral cutaneous nerve. The most common example I see is post-hip arthroscopy, and we do see that the anterolateral portal of the hip arthroscope can definitely create some scar tissue and adhesions that can affect the lateral femoral cutaneous nerve. I remember one excellent case of a soccer player who, after her surgery, when she got back to playing, couldn't actually stride out in her run without getting pain down the lateral side of her thigh. We used this technique, I think, 2 or 3 times, and basically completely resolved her pain. So this is a direct technique. It's in plane and short access to the leg. It's a 0.3 by 50 millimeter needle, so a smaller needle there, and we're using the linear transducer. Here we have our anatomy. We've got the rectus femoris. We've got the sartorius above S, and we've got the TFL over here. We're coming in from the lateral side on the left. As I say, rectus femoris below, and then just next to sartorius is this bright little spot, which is the lateral femoral cutaneous nerve. So that's where the nerve lives, just at the bottom and the right of that little triangular fascial encasement that's at the top of the ultrasound image. And so this needling technique, again, in plane to the ultrasound transducer and coming in from the lateral side. And then as we have a little look here, if you're identifying, there's the needle, I'm a little superficial. Then I get into the TFL and I can needle that TFL very close to that nerve. We come across, we can also come from the medial side and needle the sartorius on the other side of that nerve, and just needle all around, just underneath and around to the medial and the lateral side of that nerve. Without hitting the nerve, we can be very accurate. We know where we are. It's much more comfortable for the patient, even though it's a small sensory nerve. It's not nice if you do hit that. Another example of that is the posterior interosseous nerve. And so with the posterior interosseous nerve, here's our anatomy. We have this, the radial artery as it comes down through the anterior aspect of the elbow. We have this RRA, which is the recurrent branch of the radial artery that branches off, curls back on itself. And curling underneath the recurrent branch of the radial artery is the posterior interosseous nerve, which is the deep branch off the radial nerve. So this supplies the hand intrinsics. Then we have the superficial radial nerve running over the top of that. Now, this muscle, the supinator muscle, is in close contact with the posterior interosseous nerve, and you can definitely get restrictions of that through here. This is very common in lateral elbow pain. And so needling this and releasing this can be very, very beneficial for things like tennis elbow and those lateral elbow pain syndromes. But clearly, there's a lot of vascular structures. That nerve is hard to identify. We kind of don't want to just go banging around in there with a needle without knowing where we are. So this is an out-of-plane technique. This is a tricky little technique. This is long access to the nerve that we're going to needle, but short access to the supinator muscle. It is a 0.3 by 30 or 0.3 by 50 needle, depending on the body habitus of your patient, how big their forearm is. With your athletes, it'll be a much bigger needle. And we're going to use the linear transducer. Looking long axis, we can see the vascular structure here of the radial artery, just as we pointed it out, as it runs down into the forearm. And then as we look here, we've come a little bit more lateral to that, and you can see those hypoechoic, the recurrent radial artery, as it curls back towards us in the lateral aspect. Now, the supinator muscle is highlighted underneath that in blue here, and there's our posterior interosseous nerve that runs underneath the recurrent radial artery, but also just over the top of our supinator muscle. And you can see the tip of my needle in this out-of-plane approach sitting right in the middle of that supinator muscle. And so that's what we're after here. And there's the technique coming in from the lateral side. So to summarize, ultrasound-guided dry needling enhances accuracy and safety of dry needling procedures, especially in areas that have proximity to viscera and other important relevant neurovascular structures. We can needle directly where we visualize the needle as we do the needling, in plane where it is parallel to the transducer, and out of plane where it is perpendicular to the transducer, and this allows for real-time visualization of the needle placement. And finally, peri-neural needling can be effective for pain syndromes that involve muscular compression or restriction of peripheral nerves. Lastly, I want to direct you, if you're further interested, to the AIUM practice guidelines. And AIUM did get input from the APTA and myself, Doug White, and Wayne Smith provided some feedback and input into the development of these guidelines. And I want to thank AIUM and the APTA for the collaborative nature which they produce these, and also these ongoing webinars. And finally, there are the references if you from this presentation if you would like to take a look. And now we will pull up the questions and answer your questions. So feel free to type in your...
We should have at least 2 here. Let me know if you don't see it, and I can read them.
Okay, so the first question is, how do you code for ultrasound-guided dry needling, modifiers and reimbursement? When I was practicing in clinical practice in Washington, D.C. before, practicing in a team environment, this was something that was difficult to get reimbursement for. And certainly there's even some question about, being reimbursed through insurance and some insurance companies. And I'm not sure how that has changed since I've been been in the team environment for the last 2 years with insurance companies reimbursing for dry needling. So it was usually billed as an out-of-pocket expense to the patient for ultrasound-guided dry needling. It's hard to have a direct code for that. The second question, with regard to peri-neural needling, can you objectively determine the area of compression and therefore where to direct the needle? So the long answer to that is to some extent yes, in situations where you actually have a true nerve compression. What you see in a true nerve compression is that just proximal to the compression of the nerve, there will actually be an increase in diameter of the nerve. The nerve will appear thicker, and that helps you to identify where that nerve is being compressed. I think what we're doing with peri-neural needling in a lot of cases is more or less improving the mobility of the nerve through those fascial structures. And I'm not sure that in those cases there is a true compression. And so in that situation, I generally just try to needle along the course of the nerve in areas that do tend to get restricted when you do your neural tension tests or that you identify from your musculoskeletal exam, rather than necessarily trying to find an actual site of compression. But the long answer is yes, you can identify that in a true compression situation. Are there any significant adverse responses with deeper techniques? The major adverse response you're going to see in some people is more of your vasovagal type responses. So, people feeling nauseous, queasy, a little lightheaded. And those are the people that you want to keep in your office a lot longer. But honestly, I don't necessarily think that needling, and especially needling for these deeper techniques, is for everybody. And there are some patients that even though I have the technique up my sleeve, I would never dream of needling like that for those reasons, and their anxiety levels, et cetera, et cetera. So I would use it judiciously. Just because you can do it doesn't mean you should do it. Are there any risks or concerns when needling a trigger point and the patient reflexively contracts the muscle when the needle is in their tissue? Yes, that has happened to me in one situation in my career where I was needling the flexor digitorum longus in the shin in a large athletic patient who contracted at the same time as the needle went in, got a very large muscular contraction. And it did bend the needle. The needle didn't break, but the needle did bend, and that was something that was painful for the removal of. That has happened once. It's something that I think is quite rare. As I said, I've been needling for a very long time, but to be honest with you, that would certainly be something that I've seen. Is there any research to support better safety and efficacy for using ultrasound-guided dry needling compared to blind dry needling? The answer is no. There's no studies that I have seen really looking into this. However, there are studies that look into ultrasound-guided injection procedures, and definitely those seem to be much more efficacious. And I think, whilst I can't speak to dry needling, directly from those studies, there's enough evidence to suggest that being more accurate does improve the results with injection. Ergo, it's likely to improve results with dry needling, but we definitely need some research in that area. And maybe you're volunteering to do the next study. That would be great. Do you think that dry needling has more positive effects than manipulation? No, I don't think the idea of a technique such as dry needling and or manipulation is to try to compare them to each other and to make a judgment that one is better than the other. I think that there are appropriate situations for dry needling. There's no question that manipulation has effects on peripheral nerves. We know that central manipulation does that. I'm a therapist who treats very centrally. I needle centrally for peripheral effects. I will needle at the nerve root of a muscle that I'm trying to affect with a peripheral needle. I will manipulate and mobilize centrally to get peripheral effects. It is a combination and an adjunct, and I think this is where some of the studies into dry needling fall down, is that they're assuming that one only dry needles, and that is the treatment, and that, you know, the long-term effect of dry needling in some of these studies has said that, you know, whilst you might get a short-term gain, you don't get a carryover long-term. Well, my argument is that it's not meant to be used that way, in my opinion. If you look at Jay Shah's work and seminars that he's given, he also implies the same thing, and I think that that's more misuse of the technique. So I don't think it is more effective or less effective. I think that there are different techniques that can affect the same systems, but they're used often complementary to each other. I'm hoping to look at the differences in muscle contraction visible on ultrasound with eStim delivered via dry needles and surface pads. Any advice? That might be a question that we answer in a little more depth once we're done with the webinar, but I'm happy to discuss that. Do you use ultrasound guidance over the thorax? And the answer is yes, I do. And obviously for the reasons of having the lung fields underneath there. So I do find it useful. There are some areas in the thorax where you're quite safe when you get into very close to the spinous process and into the gutter there of the spinous process and lamina. But once you start moving out peripherally into some of those periscapular muscles, it can be very useful. All right, I recently tried doing ultrasound-guided dry needling for the lateral femoral cutaneous nerve. Never considered it for the posterior interosseous. I will consider under the lateral head of the triceps, given the recent BMJ case report. Any thoughts or suggestions? Yeah, I mean, I'm glad you tried it. I'm glad you got a really good result with it. And thank you for letting us know that worked. And I'm excited that somebody else is getting a good result. If you're going under the lateral head of the tricep, the radial nerve is much bigger there. And I think, you know, it's much easier to see. So I would say you probably find that it won't be as difficult as the posterior interosseous. I think you'll find that radial nerve is really quite obvious there before it bifurcates, and I think you'll be quite safe. Just to confirm, are you saying perineal or peri-neural? I'm saying peri-neural, so around the nerves. Our dry needling adverse event paper showed the risk of a significant adverse event was less than 0.04%. How much safer can you get? Clearly it is useful for needling major arteries, nerves, and internal organs, but do you think that ultrasound-guided dry needling really makes dry needling that much safer? You know, I think it depends on what you're needling and the experience of the needler. This question's coming from somebody who's incredibly experienced, and I'm grateful and thankful that you joined, and happy that you're commenting on this. But I do think that I do find in areas where, let's take an athlete. If we hit a blood vessel, you know, in certain areas, a vein, what have you, it may not be that relevant in a patient, but in an athlete, it may be really relevant because a bleed there can actually delay the return to play or the effect that we're trying to get. You know, blood is definitely an irritant around nerves, and it's definitely an irritant in muscles when they bleed. It's, you know, we know that if an athlete takes a hit to a muscle and bleeds, they're out for several days to weeks. So, you know, I do think that it helps me. I do think that it helps me to be more accurate in that sense. And an adverse event that lands you in the ER is very different for me from an adverse event that says that my athlete can't practice tomorrow, which in my world is an adverse event when you have a coach yelling at you. So What value do you place on good palpation skills? I feel they are most important. Do you agree? I 100% agree. And when I teach on ultrasound, the biggest thing that I tell people is that our eyes and our hands are our two most valuable tools, and ultrasound is purely an adjunct to those tools. And so, people get so focused on the ultrasound screen when they're using ultrasound, and they forget the patient that's in front of them. That's a big mistake. And I am very, very much in agreement with your comment that our eyes and our hands, as I said, I had a little conversation with Darcy offline prior to the webinar, and I was saying I probably use this type of needling much less than maybe I would have earlier, because of my experience, and also just knowing what it works for and what it doesn't work for. And I agree that eyes and hands are very effective. Have I had any success with cervical dystonia? Great question. I actually had a patient with cervical dystonia back in my former life in Australia, and I did use a significant amount of dry needling and ultrasound-guided dry needling for the SCM, just to avoid the external jugular there. And look, we know that there's a large central component in dystonias. And so to the extent that we're able to temporarily improve range of motion and temporarily give relief, yes. To the extent that there was a long-term benefit, no. That patient went on to go to have Botox injections, which did give some longer-term relief, and there's definitely some support in the literature for that. But I did not get a long-term relief in cervical dystonia, and I would suggest that's because of the central component to that. There appears to be an increase in PTs causing subdural hematomas with dry needling. Do you use ultrasound-guided dry needling for needling the multifidus muscles? I do use it for needling the multifidus muscles, but I got to be honest, I generally don't ultrasound-guide dry needle multifidus. I feel like I'm experienced enough, and I know where that lamina is, and I can find that. I've used it to assess and reassess multifidus muscle function after I've done the dry needling, and I definitely have observed improved function of the multifidus muscle after dry needling, especially in multifidus that's in spasm. But I generally don't use it during the technique myself personally.
Are there any final questions? Going once, going twice. Oh, here we go. See?
Okay, how valuable do you consider M-mode ultrasound, superior specificity and sensitivity in detection of pneumothorax versus radiography? So M-mode ultrasound, for those who may not be as familiar with ultrasound, is a temporal sequence of ultrasound where you can see the muscles contracting temporally, or whatever it is that you're looking at in a temporal sequence across the screen. So you get the depth of each tissue, but as opposed to B-mode ultrasound that you saw throughout this presentation, you don't actually see the structure per se. Honestly, I don't know the answer to that question. I have not used it as a method of detecting a pneumothorax, so I couldn't answer your question. I'm sorry.
All right. Well, thank you. Thank you very much. And on behalf of the AIUM and the APTA, our thanks to all of you who participated in tonight's webinar. Please remember to complete the post-test and the activity evaluation, and we hope you enjoyed this presentation and will join us again for future webinars. Good night, everyone.